Welcome and thank you for taking time to attend this webinar session by Society for Quality Health Kenya on the role of the regulator with regards to quality health care and patient safety. First of all, I would like to thank KNH for allowing us to use this platform, and we thank them so much because this is not the first time, and they have been allowing us to use this platform to share this very important information with healthcare workers. And I'll also want to thank the many participants who are already on board, even as we continue to expect more. And my sincere appreciation to our two presenters, that is Dr. Talam Kimayo and Dr. Kanja Stella, who agreed to slot in this time in their busy schedules. Thank you and welcome. We are all ears here to hear what we should expect from regulators so that we are able to follow what is required of us and also to advocate for what is required for our patients to receive quality care and to enhance their safety as they receive health care. And all protocols observed, I would like to welcome all of you. And first of all, I would want to ask, who is a patient? Because our business here today is about quality healthcare and patient safety. Who is a patient? I think this is a rhetoric question, which all of us are able to answer. And first of all, I would want to say, all of us are potential patients. Even if you are not a patient today, tomorrow you could be a patient. And so we need to receive this quality care, and we also need to be safe while we receive the care. So we are in the right place to hear what our medical and nursing council have in place to ensure that healthcare is of quality and it is safe. Thank you and welcome all of you. I would like to introduce our first presenter, Dr. Edna, and allow me to read her bio. Just a moment. We are doing very well. We have quite a number of people who have joined us, and we are glad to see them. Okay. Dr. Edna C. Talam Kimayo is a global health champion and a national leader in transforming Kenya's health system through regulations of nursing education and practice. She has held a number of senior management positions in the nursing profession over the past 13 years. She is a nurse with corporate leadership and governance credentials and hands-on experience in developing national health policies. Edna is currently the Registrar and Chief Executive Officer of the Nursing Council of Kenya, the statutory board mandated to regulate nursing and midwifery education and practice in Kenya. She oversees the management and administration of the council's functions and activities, legislative compliance, providing leadership and strategic direction to ensure that quality standards of nursing and midwifery practice in Kenya are upheld. She holds a PhD in nursing science from Stellenbosch University, South Africa, a master's degree in public health from Kenyatta University, bachelor's of nursing, science in nursing, that is BSN, from University of Eastern African Baraton, and she's a fellow with Global Health Leadership Program, University of Washington. Her rich and vast experience has inspired her to develop advanced research skills to help lead nurses and midwives towards building health systems, research capacity for promoting progressive healthcare policies. Her interests are anchored in strategic leadership, maternal health, monitoring and evaluation, quality, performance improvement, and policy development and implementation. Welcome, Dr. Tala, to speak to the audience. Thank you.
Thank you so much, Lois. And I just wish to quickly share my slides. Which I hope you are able to quickly view them.
Yes, we are.
Thank you so much. And I'm very glad to just have this dialogue and welcome our participants. We've hit 261, and I'm just glad that we are going to have this conversation basically today. Okay, so in regards to, I wanted to put on my video, but it's fine. So I'm just going to quickly just have a conversation with all of us in regards to how is the role of the regulator in advancing patient safety and basically quality of care. So when we talk about patient safety and what is the role for the Nurse Council of Kenya, which it is really pivotal in regards to ensuring patient safety and advancing the quality of healthcare. You will see in the next slides that part of the mission of the council is to ensure that we enhance the trust in the public and ensure that there's also public safety for the health professionals that we do regulate, that they should be able to give the care. The council, again, is essential in upholding competence and also ethical conduct of nurses and midwives working in Kenya. And at the same time, it also contributes to promotion of patient safety and enhancing the healthcare outcomes in our country. Just to quickly highlight who we are, the Nursing Council of Kenya is a body corporate established by Nurses and Midwives Act of the laws of Kenya to regulate the standards of nursing education, nursing and midwifery education and practice. So our vision is that we visualize to have a safe and healthier world, that everyone who is within this world, irrespective of where you are safe, and we have a world which is healthier. Our mission is to regulate and enforce standards in nursing and midwifery education and practice that inspire the public safety and confidence. So this conversation is very, very important because part of our mission is to inspire public safety and confidence. And when we are being asked who is a patient, any one of us is a potential to be a patient. You can be a patient at any point of your time, and you are part of the public for us to do that. So talking about patient safety and saying that why is patient safety important in this healthcare system and this conversion when we have. When we talk about patient safety, we actually think of ensuring that we prevent the patients in errors and adverse effects to patients during the provision of healthcare services. We do not want to have any medical errors, whether it is omission or commission. We do not want to see any errors as we provided this care. And of course, those adverse effects that are coming with these errors. There's also the absence of preventable harm during healthcare provision. And we should be able to have an accepted, it should really to be a bare minimum acceptance. Again, it involves proactive measures and protocol, which should be implemented to reduce risk, minimize harm, and also ensure the well-being of the patients. It also requires collaborative efforts because we just work as a team, and the issues of patients' care, patients' management, all that is actually a team effort, from the person who registers the patients in the reception, to the person who hands over the file, to the person who prescribed, to the person who provides the medication. So it is a whole collaborative efforts to ensure that all healthcare professionals, the administrators, policymakers, patients, and even their families are part of this conversation. So the key aspects of patient safety First, the one that we started having this conversation is in regards of ensuring that we prevent the medical errors. That part of it is that we should not be able to have medical errors. And then how do we do that? We'll be having a conversation of how we integrate the technology to avoid patient medical errors that we have. Again, we are also talking about then issues of ensuring that there is also effective communications. And in regards of effective communication, it is having communication which are a bit clear, it is concise among healthcare workers and patients, so that it is crucial for them to avoid misunderstanding that could lead to any errors. For example, if these are the patients that they are even having home-based management, we need also to be able to effectively communicate to them for them to just know the dosages so that they do not misunderstand what are the management that we are providing on it. Infection control, we need also to implement measures to prevent health-associated infections, such as issues of hand hygiene, sterilization, maintaining clean, and also healthier environment. So it is quite important that the key aspect of patient safety also goes within the infection control. You know, the issues of the sharp infection, issues of the things that we need to ensure our environment is safe for the healthcare professionals and also safe for the patients as we provide them. Again, medical safety comes in that we need to ensure that we have correct prescription, we administer the correct drug, we monitor the medication to prevent adverse reaction and also the medication errors. So the medication safety is also quite very important, and it ties on reducing the issues of the medical errors. Continuous quality improvement is something we cannot underestimate. When we talk about patient safety, our environment needs to be, we need to be ensure that we have continuous CQI activities, assessing, improving healthcare practices, reviewing our protocol systems to enhance patient safety based on the data that we've collected and also the feedback we provide to them. Patients' involvement, which also ties on effective communication. How do we ensure that as we talk about aspect of patient safety, we also have the patient's involvement? And in regards of patient's involvement, how do we ensure that part of the care that we provide is also the patients, for them to also, we encourage them to actively participate in their care, to provide the correct information, because that correct information will be able to help us to be able to determine the correct management of that. We also want to encourage them to ask questions, query even the treatment options, which can be able to prevent errors and also improve their safety. Healthcare provider training. Again, as we talk about the healthcare provider training, proper education, training, and ongoing professional development, we need to continuously to maintain our competencies, our skills in regards of the patient safety practices. Integrating technology is important, especially issues of electronic health records, so that we are not able to actually have other patients that we have always had these conversations of the errors that it happens, the incidences that we've had in our hospitals, where we have issues of identification of our patients, and it actually leads to a lot of medical errors that we've actually seen in the limelight. So we need also to ensure that we have electronic health records, clinical decision support system. We need to also streamline our processes and also reduce errors in the entire healthcare delivery system. So it's a sort of a processes that we need to integrate technology, so that even as the doctor prescribes the medication, it is within that technological paradigm that then we don't have the issues of transcription errors that we can be able to see from time to time. But then technology, we should be able to support them. And by and large, ensuring this, it's more of a collaborative effort to ensure that all of us are part of these conversations in that. As I move to my next slide, we'd say this, and then why patient safety? And why is patient safety important? Patient safety is important because in our previous conversation, we've just said that it is common in the course of healthcare provision. And we are talking about issues of safety. We are talking about us being efficient, us being effective, and also ensuring that we have patient-centered approach for us to enhance the high quality of care, accessibility, timeliness. So it's all surrounding that. This is what it is important as we provide the care. Again, it can be able to lead to to issues of permanent injury, increased length of stay because of the errors that we've caused, and in some extreme even it can cause part of the mortalities and morbidities. Annually, the deaths are associated with healthcare providers outnumber those from road accidents, breast cancer, and all that thing. So this is basically part of the quick statistics that I needed to be able to do that. So in a nutshell, the patient safety is paramount to ensure that we prevent harm, we reduce the errors, including complication medical errors. We enhance the quality of care that we do provide for our patients. We need also to ensure that we build trust and confidence, that the patients and families rely on our services because they do trust us, and we need to prioritize the patient safety for them to be encouraged and to seek necessary treatment without fear or avoiding any harm. Again, we, in regards of ensuring that we do not increase the length of stay is also to ensure that we also optimize on the costs that they are there, that reducing the healthcare costs, which is associated with medical errors, advanced events as a result of this increased high costs because of prolonged length of stays in the hospitals. Patient safety initiative also ensure that we reduce these avoidable costs, and again, improving the outcomes and ensuring that there is ethical responsibility together as we basically move on to have these conversations of why then is it important. Coming back again to then, why is then the regulator there, and why are we coming in to say what is really the crucial role of the regulator in patient safety and ensuring that we enhance the high quality of care? First, I make sure that we protect the public. And how do we protect the public? We protect the public because we set standards. We ensure that the standards conform. We ensure that the people that we are releasing them to the public are competent and they are confident to be able to offer the care. Say that now, if you need to be able to know that Edna is a nurse, you are able to go to our portal and you are able actually to satisfy that indeed she has all the competencies, she has the educations, and she's fit to practice. And this is where we just say that our role is really to really protect the public of who the patient is part of that conversation. Again, in regards of that is also collaboration and advocacy with the stakeholders, setting and enforcing standards of nursing and education and practice. So the standards are set. So we have procedure manual that is actually spelled how the process should be able to do that. We have standards of care that yes, this error or this patient safety was not being able to have been done because then there were less nurses in the ward or healthcare team, or again that the patients fell down because the infrastructure was not appropriate, or the patients fell down because the floor was not, in an environment that it was supportive, So all those things are the one that we basically set. And I know my colleagues from Medical Council will also be able to talk more about our approval processes and ensuring that part of our infrastructure and equipments are in a manner that it actually ensures that the patients are safe. We also monitor and evaluate standards of nursing and review education and practice so that the education we do provide conform to really conform to the practice, so that we are also ensuring that the emerging and re-emerging issues are part of what we do in our midwifery and nursing educations, and also supporting the practice. We set the requirements for registration and retention of the nurses and midwifery professionals, and that is where the issues of annual retention, ensuring that we have the minimum CPDs points, we train and we retrain and ensure even in regards of communication, personal relations, is what we have these conversations with our nurses for us to ensure that we provide safe practice for the patients. Remember, again, part of what is quite important to reduce the patient safety is also the collaboration and the communication with our patients to understand that they are part of this management, for them also to be able to take instructions and to prevent these issues of patients not being safe in our environment. Again, quality improvement initiative, I had said, and so that we need to also be able to ensure that we adapt to its advancement. Then, what is it that we put in place at the council to do that? And I'll quickly mention the broad three areas that we work on in regards of education and training, issues of effective recruitment, management, deployment of the students, going to the training methodologies, educational standards and accreditation, ensuring there's clinical instruction side that the theory is translated to practice, faculty and instructors, and ensuring that there's also competencies assessment, that the people that we place them to be able to deliver the content to our students, to our learners, are the people that they are competent and they are fit for them to be able to deliver these content to them. When we talk about registration and licensure, we ensure that we have integrity of our register, that you cannot enter the register if you've not been able to manage you from the students. So you start from the indexing to ensuring that you do your exam, to ensuring for those who are BSNs, that's the internship, for you to be able to register and again to be retained. So the technology has supported us and the processes are supported to ensure that you don't come from nowhere and you just want to be a nurse. You ought to have been part of the system, and we've ensured that we have monitored and evaluated you and gone through the processes to ensure that whoever enters into a register is fit to practice. And that's what I talk about, integrity of the registration of the register by the council. Again, the recognition of professionals from other jurisdictions, ensuring we do the certification and also accreditation. Finally, in regards to professional conduct and practice, moving from being the student to the registration now to the practice, ensuring that there's regulatory tools and guidelines, we do monitoring and evaluation, and we enforce standards. That I do not want to also underestimate that the fact that you have the professional misconduct, professional malpractice, then we'll be able to enforce the disciplinary parts as part of what the council does to enhance this public safety in that. So within that, again, as I basically try to summarize, because I can talk until tomorrow on issues of regulations, we are protected by the Constitution of Kenya, which really spells out that the rights for highest attainable healthcare as a citizen of Kenya. So we are enrolled with these legal authorities. The council plays this crucial role in setting and enforcing standards of nursing and midwifery education. We are talking about from the Constitution to our Nurses and Midwives Act, Cap 257. Again, we collaborate with educational institutions to ensure that the programs align both at the national and international frameworks. And again, through accreditation and continuous engagement, the council also seeks to elevate the quality of education and also training methodologies as we move in regards of what is it that we have to ensure that we inspire the public safety. Licensing and registration and CPD, we've spoken about that, and we also ensure that we are a linchpin in maintaining a qualified workforce. We oversee the licenses, the processes that we've talked about, and at the same time, we have the commitment to professional growth to ensure practitioners stay abreast of evolving healthcare practices. They contribute to the overall proficiency of a healthcare workforce. And this is where we are in the council, and this is what
Dr. Edna, I can't hear you.
Code of conduct and ethics to ensure that you work and you have this code of conduct and ethics. And again, the standards of nursing and midwifery practice, scope of practices, the manual of clinical procedures, issues of training guidelines, CPD guidelines, and also internship books. This is what the council has in regards of setting the standards and ensuring that we maintain these standards and we also enforce the standards. Quality assurance and collaboration, we do continuous assessment, we do compliance audits to ensure that we are rigorous in our quality assurance. We conduct the audits sometimes alone, and we also have the joint inspection teams, which is run by the boards and council to ensure that we uphold the healthcare standards. Through these collaboration efforts, again, with other stakeholders, we ensure that we nurture partnership, we enhance the patient care, and also we promote a unified approach to quality over the healthcare. Technology and innovations, we embrace technological advancement. The council employs innovative solutions to streamline our regulatory processes, which I've been able to mention. We are part of the Kenya Health Regulatory Human Resource Information System. We have the online services portal, and at the same time, you can be able to view our services, which we have been able to onboard, as even guided by the government of Kenya. Again, the digital platform plays a pivotal role in ensuring that we ensure that we are efficient, there's accuracy in management of healthcare professionals' records, which we have been able to adopt that. So as I summarize, is that we are having bits and pieces to be able to advance the nursing professional towards patient safety. We are talking about the digital health, use of digital tools to make accurate diagnosis. We are talking about research, conducting comprehensive research, data mining, data analysis, implementation stands to identify the specific areas of improvement, innovations, for us to be able to improve the nursing care delivery, virtual simulation that we are going now, that the AI is here with us and we need to keep abreast on it, issues of technological application and learning, and nurses and midwives are central placed as coordinators of the healthcare and to strengthen the digital healthcare ecosystem that we are part of it. So as I conclude, The Council, through our regulatory prowess and collaborative endeavors, will emerge as a linchpin in the pursuit of patient safety and quality of care. The role of the healthcare regulators in advancing patient safety is to ensure quality of healthcare in Kenya is really undeniable. Our stakeholders plays also an important role in our journey towards a safer and more effective healthcare. And as we navigate the challenges of the ever-evolving healthcare landscape, the Council remains steadfast to ensure that we are committed to the excellence, we shape the resilience, and we are proficient healthcare workers for the benefit of the nation. I want to just say patient safety is a collaborative approach. We have to come together from ourselves as healthcare providers to the policymakers to ensure that they provide the correct resources, to the patients themselves to ensure that they are part of the decision-making. They are part of even them guiding us to ensure that we reduce of the medical errors. And overall, it's actually about the policies that we are in place, and together we can ensure that we enhance our patient safety. I just want to say thank you so much, and I'm glad to be part of this conversation. Over to you, moderator.
Thank you so much, Dr. Edna Talam. We appreciate that is great information that I'm sure some of us didn't know there are all these goodies happening in our nursing council. Basically letting us know how the council is working towards advancing the nursing profession towards patient safety. It's really exciting. And seeing all that is in place for us to be able to ensure that the safety and quality of care is the in thing while we are giving our services. Key also to note is what you shared on the 8 aspects of patient safety. And I think without a doubt, every one of us can relate with each of those aspects, starting with continuous quality improvement and the IPC, which is personally is my bread and butter, and also communication. Communication is very important as far as enhancing the quality of care and ensuring that our patients are safe. And many a times we have challenges even in our documentation, which is part of the communication, that sometimes we omit, sometimes we document things that are not clear on regarding our patient care, and we end up having our patients harmed. So this is very exciting. As we also consider patient engagement in their care, because care has to be patient-centered, and making sure that we are engaging the relevant, all the relevant stakeholders in our patient care. So, and the closing, the team effort part of it is very important, that we know we are all responsible for the care we are giving, the quality of the healthcare services we are giving to our patients, and also their safety is a team effort. And you also added for us, what would happen if we don't make sure that we adhere to all these great things that our councils have put in place, and that is the outcome of poor care. What will it happen? And it starts with extending the stay of the patient in the facility, and it extends to even death, where a patient can be harmed and end up with morbidity or mortality. So thank you so much. And I would like to open the floor briefly for questions for Dr. Talam. Members, participants, kindly write your question on the Q&A provided chat platform on the Q&A area. Meanwhile, if there is any of the panelists with a question, I would give them a chance as I wait for questions from the participants.
Lois, thanks so much. I think the question that someone has asked is something not really related to this patient safety, but I just want to just say that we do the reporting of CPD after 72 hours. And I just want to urge that they can quickly get in touch with us in case they need further information. Over to you.
Thank you, Dr. Talam. I see a good question. I see one question, and it reads, what specific tools does the Nursing Council of Kenya use to ensure you have said is adhered to? Or this is what you have reacted to, Dr. Talam?
Not really. I had not seen that. When I did my presentation specifically in the slides that I was talking about, what is it that we do to ensure that is adhered, I gave a sort of strategy that we ensure. So first, I talk about issues of ensuring that the professional is competent and professional CPDs are done. I think that's what I mentioned. I also mentioned issues of standards that we've set and the compliance that we are able to do. I mentioned about standards that we have, code of ethics, standards of nursing practice, scopes of practice, manual, and I also quickly also mentioned the issues of quality assurance and collaboration. A lot of institutions, even including KNH, has gotten our input in regards of the quality assurance that we do on part of the system, so there's a patient's care and done. And as I mentioned again, we do joint boards and council inspections in our health facilities. We give feedback and we just ensure that we stay abreast in regards of that. I also mentioned issues of technological, unless then the participants needed anything specific that I did not basically be able to capture. Please also know that the council has a board and we do quarterly reports. Again, we are guided by strategic plan. We're also guided by performance contract. And again, these are the things that it is documented and they are available in regards to that. I just want to just quickly hand over to you. I also want to also have another issue which these are other things that I will request colleagues. Could you wish to be able to just mail the council and then we can be able to guide you, because issues of do you have register for nurses? I think this is part of administrative things that we can be able to answer. Yes, indeed, we have these processes and we're in the process of doing that. And then issues of that updating, I just want to wish that our processes is 72 hours. We'd work to ensure that we can be able to reduce the time as we review our internal processes. And then in regards of patient safety, what about healthcare workers' safety? I think conversation today was more of patient safety, but again, we also have a lot of things, even in our institutions, and I think I can throw back to the team of KNH to help. What are the other things that you do to also ensure that the safety of healthcare workers? We have OSHA guidelines. We have a lot of conversation in regards of healthcare safety that we have always been able to advocate, ensuring the correct infrastructure, they have the commodities, the environment is basically safe, and that. Jonathan, I think your issue is also quite okay. Yes, we do regulate that, and thank you for asking that. And then in regards of the regulator upholding the no blame culture, particularly in that, I think we stand in because then we are the one to ensure that we provide the public safety. And in regards of no blame culture, I did mention that collaboration is important, the teamwork is important. The patient is for every healthcare providers, including the cleaner, including the watchman, giving instruction, and that is what I just say, that we need also to ensure that our systems are working for us. We need to have the continuous quality improvement system in our institutions to prevent system errors, ensuring our processes are effective and efficient. Again, research scholarship, the council is really not a research, our core mandate is really not research, it's more of regulations, but I'm sure, Ann Kimani, you'll be guided on institutions that they provide scholarship in the country, and we can be able to support you in regards of getting the grants that you need to be able to do that. Again, in the private sector, what I shared cut across the public and private sector, and each institution also is all responsible to ensure that the patients are safe, and there are sanctions that we need to be able to do that for that. Then we are happy to share the presentation. And I just want to just say that thank you so much for all the things that you've been put in place. I will be able to also collect all these other informations for us to be able to help and to basically support you. I hand over to you, Lois. I'll basically also to see if there's any other new emerging theme apart from what I've just been able to talk about. Over to you.
Thank you so much, Dr. Edna. I don't know whether you've seen one by Mary, which is asking, how do you address the shortage of nurses issues? Because it is a factor in patient safety.
Yeah, fair enough. Thanks so much, Mary. I think that one just came in as I was wrapping up a minute ago. I thank so much, Mary. I totally agree with you that when we talk about patient safety, part of the thing that it ensures that we have medical errors are that is the extreme shortages with that. As I mentioned to you that we audit institutions and we also give them that. Part of it is actually a whole of collaborative approach where we need to be able to lobby and advocate for the resources, more of the finances from the treasury, and also to ensure the prudent management of those resources, that when the county government is given the resources to employ the nurses, we are able to ensure that they actually really enroll the nurses. And even I've told them, Mary, in part of our meetings, and I've just said that please ensure that if we audit your register and these are the nurses, please stop sneaking in drivers to be part of the nurses workforce, and I'll let that be that. And again, part of also the conversion which we've done, and we've seen a bit of gains, Mary, together with our associations and also union for the collaborative efforts. We've seen a lot of counties that they've been able to advertise for the nurses, to include of the nurses, because we've given them a lot of input and that. But by and large, it is a continuous conversations, because it is about issues of ensuring that there are resources. There's the proper budgeting, there's the workforce planning and management. Right now, the issues of immigration, we really need to be able to take a proactive approach. Not only the regulator, it's the regulator, the team that they are, the CEOs of healthcare institutions, the facilities, the nurses in charges, the directors for nurses, whoever who works on the workforce planning should be part of that conversation, so that we can be able to do projecting, we can do plan, and we can advocate for resources, and we ensure that in the next 5 years, this is the number of nurses we need to be able to do that. But we are on top of the game. Mary, is really not an easy thing. It's something that it is continuously, because replacement should be something which is continual and it should be part of the budgeting. But it's really a very useful input that if we can be able to address the shortages of nurses, we can really improve in regards of the patient safety. Over to you, Lois.
Thank you, Daktari. And I thank Kelly Roy for the information he has shared on the Q&A area on the various services that NCK, National Council, Nursing Council of Kenya, is able to provide. I can see quite a number of people concerned about the CPD points. We'll be able to, if you have logged in officially with your email address, you'll be sorted out within 72 hours. And if not, then you need to reach out to the relevant stakeholders within Kenyatta to be able to get that worked out for you. One more question from Dr. Bessie. Are you ready to collaborate for collaborative research with the university to promote patient safety? I think this question is directed to you, Dr. Talam.
Yeah. Of course, Betsy, of course. In fact, the grant that we just did the other day, we have worked with many universities. We've even worked with Aga Khan and these others. We work with various universities to be able to support them. Please, we are very, very happy, as Kelly has put in the WhatsApp. I think let us quickly catch up on this conversation. And Kelly, you can just be able to provide the CEO's email in regards to the chat box, and we can basically pick it up. We are very, very happy to do this collaboration because this is part of us. As I mentioned in my slides, we also have the conversation of ensuring that we have collaborative research, and universities, because you are part of the scholars, you give us the research and us we implement, but we are really very great to be able to be part of these conversations. Absolutely welcomed idea, and thank you.
Thank you, Doc, for that response. And I can see many of them are appreciating and thanking you for the presentation. And we have one more before we get to our next presenter. Let me read it. It's from Walter. How do we have regulators together on issue of quality to assist minimize errors that emerge due to too many parallel approaches that target the same patients? Can you consider a national quality award that encompasses all cadres?
Okay. Yeah.
I guess this is, as even we say, is a team effort. How do we coordinate these team efforts seamlessly so that we are not running parallel?
Yeah.
Over to you, Dr.
Yeah, fair enough. You know, the good thing is that most of the people are not even aware there's a Society for Quality Healthcare Kenya. And because of competing priorities, I think I want to throw back to the Society of Quality Healthcare to just ensure, in regards of National Quality Award, within a strategic plan, please give us the strategies that you want us to be able to ensure that we have the National Quality Award. In regards of having all regulators, I've said that the regulators, especially the healthcare regulators, we are together. We do the joint inspection. And even we also do joint inquiry. And I can testify, and my colleague David, Dr. Karaoke, will actually talk about it, that Nursing Council of Kenya and Medical Council, we are together. We know there's nothing a doctor will do that a nurse is not part of that. There's nothing a nurse will be able to implement which the doctor is not part of that. So we always say that we are conjoined twins, or we are married in this partnership of giving healthcare providers, and we really work together. So we work together to ensure that we do joint inspection, if there's inquiry, if there's that, and we are fair in the table. We bring the issues the way they are, and we actually try to get the root cause analysis. And nowadays, even how we conduct our inquiries, we are supportive regulators. We are no longer a punitive regulators. And if there's an aspect that we need to be able to improve, we are happy to be able to do that. But Walter, let's pick this up. If you see that there's the issues of us not coming together, please tell us the areas for improvement. And I throw back to you to ensure that by end of this financial year, we have a National Quality Award. We are in. Thank you.
Thank you so much, Dr. Talam. And on that, I would also want to bring in our president for Society for Quality Healthcare Kenya, Dr. Oktui, if she can add something to the issue of National Quality Award. Welcome, Dr. Oktui.
But before Dr. Mutui, Lois, I also want to acknowledge that we don't only work with Medical Council, we work with Clinical Officers Council. So let me use the word clinicians as opposed to just doctors. Yes. So we work with all clinicians who are part of these conversations, and we work together. Thank you.
Thank you so much. That is important. Dr. Oktui.
Thank you very much, Dr. Edna. I think the industry acknowledges the role of regulation, and especially nursing, because it cuts across everywhere. So thank you for taking time to give us the highlights. And I think the questions are a mark of how this topic has a lot of interest. And we know that once we get nursing right, it is the backbone of healthcare. So we are all clinicians, but nursing has something special. The encounter with the patient is extremely high. And so we leverage on that to change many other things. Yeah, just to comment about the healthcare awards, I think Quality Healthcare Awards have been run in conjunction with MOH, not quite Society of Quality Healthcare has just been supporting at the level of supporting judging, the judges, and just the logistics around it. But Dr. Grace Ndegwa and the team have done a great job. I think the last few years, almost 4 times. I think the next will be either the 4th or the 5th edition that comes next year in April. But we know that recognition is an important thing in healthcare. And so whenever we can have the more, the merrier. It can happen at counties, across cadres, and as we strengthen our system. So I think as a leadership of any industry, the more we are able to celebrate those who stand out, the better. So I think the conversation that have come here are about collaboration, working together. So I think it's about just being open to how can this improve, and how can what is happening elsewhere be made better. And so we look forward to whatever effort. And I represent Society for Quality Healthcare, but I also represent KNH, and we work very closely. Nursing Council works very closely with what happens in KNH. I just mentioned there's something called the nursing practice training that has been going on. And I wanted to mention that, Madam CEO, I think that is an impactful way of standardizing care and empowering nurses in how to do the nursing care documentation. I don't know whether I've called it right, but it has a lot of potential to help standardize it's called nursing care practice. Yes, just to say that we have tested that as KNH, and we hope that it can be scaled across the country. Thank you very much.
Thank you, Dr. Oktoi, for those great remarks. I think we need to transition to our next presentation from the Medical Council, and we will receive it from Dr. Stella Kanja. And Dr. Stella Kanja is a medical practitioner, public health specialist, and healthcare manager with 12 years experience in the public health sector. She is the Assistant Director, Standards of Professional Practice at the Kenya Medical Practitioners and Dentists Council. She has a keen interest in public health care, women's health, and quality improvement in healthcare. Welcome, Dr. Kanja.
Thank you, Lois. Please tell me if you can see the presentation. Are we able to see it?
Yes,
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 we can see it.
Yeah,
Thank you.
can see it.
Okay, thank you so much. As stated, my name is Dr. Stella Kanja. I work for the Kenya Medical Practitioners and Dentists Council in the Directorate of Standards. I'm making this presentation on behalf of our CEO and Registrar, Dr. David Kariuki, who's within the audience. And it will be divided into two parts. The first part is about KMPDC, just a brief about our establishment and roles. And secondly, about the subject matter of the day, which is the role of KMPDC in enhancing quality in healthcare. So the Kenya Medical Practitioners and Dentists Council is a body corporate established under Section 3 of the Medical Practitioners and Dentists Act, and it has a mandate to regulate the training and practice of medicine, dentistry, and community oral health, and to regulate health facilities within the country. Recently, we revised our corporate policy philosophy in line with the new strategic plan, and now our vision is excellence in regulation of training and practice of medicine and dentistry. Our mission is to regulate the training, practice, and medicine and dentistry through registration, licensing, and inspections for provision of people-centered, quality, and ethical healthcare. And our goal is to enhance quality healthcare. Our functions are many, but they can be divided into 6 categories. And the first is setting standards. As Dr. Talam mentioned, the regulators have the role of setting standards. For us, it's about the minimum requirements for entry into the regulated professions, for categorization of health facilities, and for accreditation of training institutions. Under training, we also regulate undergraduate and postgraduate training of medical practitioners, dentists, and community oral health officers. We provide the internship training guidelines and continuous professional development guidelines. In terms of registration and licensing, we register eligible medical, dental, and oral health interns and practitioners. We also register eligible health facilities and accredited training institutions. The other part of our function is a regulatory framework where we do the framework for professional practice. This is actually in 2 parts, defining the scope of practice, and secondly, about the professional conduct and discipline, so the ethical guidelines for the profession. And we also have the framework for evaluation and support of impaired interns and practitioners. This is loosely termed the fitness to practice assessment. In terms of assessment and enforcement, we have the council examinations. These are the internship qualifying or pre-registration examinations. And we have also the peer review assessments. Under that, we also have the inspection of health facilities and training institutions. Here we have what you call the routine inspections, which are carried out every 2 years or so, and the for-cause inspections, which arise when there has been an issue to do perhaps with a health institution or with a training institution. We also deliberate complaints that are lodged at the council. Most of these are against medical practitioners, dentists, and the health facilities in which they practice. And we enforce the rulings of the disciplinary and ethics committee in such matters. Our final role is an advisory role, where we provide technical advice to other organizations on health matters and to the government and other regulatory authorities. We also collaborate with relevant stakeholders to support provision of quality and ethical healthcare. In this case, as Dr. Salam mentioned, we work together as regulators within the health sector, but we are also, we work with the county governments and with the Ministry of Health to ensure that at all levels, health matters are taken into consideration. The council has 4 main committees, the standing committees. We have the training, assessment, registration, and human resource committees. We have the inspections, licensing, and general purpose committee. And we have the disciplinary and ethics committee. And finally, we have the audit and risk committee. In addition to this, we have the ad hoc committees, which are formed when there's a need, and they serve a specific purpose. And this includes the examinations board, the peer review assessment committee, the fitness to practice assessment committee, the professional conduct committee, and the CPD accreditation committee. In terms of the composition, these are the representatives within the council. The chair is appointed by the president. The regulated professionals are represented by a representative from the Kenya Medical Association, the Kenya Dental Association, and the Oral Health Association of Kenya. We also have a representative of the private sector in health. The Ministry of Health has oversight through the Director General of Health. The public is represented through a member from the Kenya National Commission on Human Rights. In addition to this, we have a representative of the universities which grant a qualification that is registrable under the Act, and a finance and audit expert. Further, we have oversight from the National Treasury and the State Corporations Advisory Committee. So coming to the subject matter of the day, which is quality in healthcare. So quality has many definitions, but I think the Institute of Medicine definition of 1990 has not exactly been surpassed since then. And quality of care is a degree to which health services for individuals and populations increase the likelihood of desired health outcomes. And this is important because quality is actually a perception and are consistent with the current professional knowledge or evidence-based professional knowledge. So therein comes the issue of setting standards. And the domains of quality have been defined as these 7, where we have quality has to be safe, not harm the patients for whom it was provided. I mean, care has to be safe and not harm the patients. It has to be provided in a timely manner. It has to be effective based on the evidence available. It has to be efficient so that there's maximum utilization. It has to be equitable so that someone receives what is best for them, regardless of any demographic variable for which they may feel discriminated against. And it has to be patient-centered. Then in addition, care has to be integrated. In this case, it means that care has to be coordinated across all levels, and where there are several providers, there also has to be coordination so that the patient is best served. It's also good to note that the domains of quality healthcare are closely linked with ethical principles and actually form the basis for most of the complaints that people make about the care that they receive. In terms of quality management, it's defined as a way of doing business where there's continuous improvement of the products and services to achieve better performance. And here, the goal is actually to achieve maximum customer satisfaction at the lowest cost to the organization while continuing to improve the process. So the assumption is that at no point will you get to a point where you're like, we've now achieved quality, so now we're not going to do anything else. We'll keep ensuring that we're able to maintain the standard that we have now reached. Yeah. And in terms of customer satisfaction, most of the complaints that we'll receive are about either someone was given a service that they didn't need, so you get the concept of overuse, or they were denied a service that they felt they needed. So there's a concept of underuse, or where a service was provided, it was not carried out properly. So there's a concept of misuse. And if you are able to eliminate these three, then you can get to a point where you're able to achieve customer satisfaction. Yeah. Again, in quality management, there's an aspect of measurement, assessment, and improvement, where we find out how we are doing currently under measurement. We determine if we are meeting the expectations, and if not, what do we need to do to get to where we need to be at? And this is actually a cycle that continues all the time. So in terms of our functions, how does KMPDC support quality in healthcare? And we can look at it from the pillars of the health sector. And in terms of infrastructure, like I mentioned, we have routine and for-cause inspection of health facilities. We categorize health facilities and we register and license eligible health facilities. Categorization of health facilities, we'll talk about it in detail in just a few slides. In terms of the health workforce, there is an inspection and accreditation of training institutions and co-curricular for training, examinations, internship training. All of these try to ensure that the practitioners who go through this system, whether they're medical practitioners, the dental practitioners, or community or health officers, will come out meeting a certain specific standard. And CPD helps to ensure that these professionals maintain the current knowledge so that they're able to provide evidence-based care. In terms of service delivery, again, we'll talk about this just in a bit more detail when I'm talking about categorization, but at every level of healthcare, in addition to that, when things don't go so well, there is the aspect of discipline. And here we'll talk about fitness to practice. This usually affects the individual practitioner, where they're not maybe doing things as they're expected to do. Sometimes due to something that may be happening in their lives. For example, they may have a health condition that's affecting their performance, or they may not have the required knowledge or expertise to carry out whatever services that they are claiming to be able to carry out. And therein comes the aspect of peer review, where the practitioner is subjected to assessment by his or her peers within the cadre. So for example, if the practitioner who has been brought forward is or who is coming for evaluation is a surgeon, then they will be evaluated by surgeons in the same field. So it will not be like a surgeon evaluating an obstetrician, or we prefer to have people assessed by persons who are in that field, who are able to tell, who have the technical expertise to assess the candidates. Then, as I mentioned, we also receive and resolve complaints against practitioners and health facilities. And in addition to just resolving them, we offer supportive supervision in that we offer advice from the lessons that are learned from these parties. In terms of ethics, we have the Code of Professional Conduct and Ethics and the Patients' Rights Charter, which is an interesting document because actually it came from a member of the public who felt that there was need for patients' rights to be advocated for within the health sector. And they were able to produce a document that now affects all Kenyans. As I mentioned, there's a scope of practice which limits how much a particular practitioner can do within their knowledge and expertise and the skill set that has been determined. In addition, we have advisory guidelines like on advertising and informed consent and other things that are also available on our website. In terms of health financing, recently we're involved in the service user availability assessment for UHC, and we have also published and reviewed the professional fee guidelines, which determine both the lower and the upper limits for the professional fees. So at this point, I'd like to move forward to categorization, and I would like to point out that we have had this categorization that has been there. Actually, it was prior to 2017, but it was documented in the 2017 Medical Practitioners and Dentists Private Medical Institutions Amendment Rules. And here the categories of healthcare were divided into 6 levels, where level 1 is a community health unit, where the professionals at this level are usually the community health extension workers and assistants, the community health volunteers, public health officers and health promotion officers, and the community health nurses. And these units are not regulated. They're not a licensed health facility, if we were to call it that. And from level 2, it's like the lowest level of health facilities, where we have the dispensary or clinics, which usually offer mainly outpatient services, but some have the capacity to offer maternity services. And here you'll have mainly nurses, midwives, and clinical officers at this level. At level 3, you'll have health centers and maternity or nursing homes, which in addition to outpatient services offer inpatient maternity. Some have basic laboratory, some have x-rays, and others at the higher level are able to offer maternity theater. At this level, you start having your general practitioners, the medical officers, dentists, and you also have the clinical officers, including the specialized clinical officers. At level 4, we have the sub-county or primary hospital, which has now, it's a general hospital that's able to offer outpatient, inpatient, theater, imaging, laboratory, and pharmacy. And at this point is where you start seeing your medical and dental specialists. Level 5 is a county or secondary hospital, which on top of what the level 4 has, it's expected to have a high dependence unit. And here, on top of the medical and dental specialists, you also have some subspecialists. At level 6 is a national tertiary hospital. And here, on top of what you have at level 4, you have HDU and ICU. And here it is mandatory to have medical and dental subspecialists. However, these were revised in 2021 and additional categories were added. And so we split. Level 1 remained generally the same. I believe now the community health volunteers are being replaced by the community health promoters and are part, or the community health unit is part of the primary healthcare network. Level 2 remains mostly the same, where you have the dispensaries and community clinic, the home care services, the standalone funeral homes. And at this level, mostly you'll see your clinical officers, nurses, community oral health officers, and therapists. These are the physiotherapists, occupational therapists, and others. Level 3 now has 3 levels, where 3A is a comprehensive health center, which also offers inpatient services, and 3B is a medical or dental clinic run by a medical officer or dental officer. And 3C is a comprehensive medical or dental outpatient center. And here, basically, they will have the medical or dental services. And on top of that, they're able to offer other services like the imaging and the lab, but they're a purely outpatient center. At this level, you will see more of your medical and dental officers and the specialized clinical officers, nurses, and therapists. Level 4 is split now into 2. 4A is a primary hospital, the sub-county hospital, which offers inpatient services and theater services. 4B is a specialized outpatient clinic, which will be run by the medical or dental specialists. So at this point is where we start seeing the medical and dental specialists as a mandatory requirement. Then at level 5, we have 3 levels, 5A, 5B, and 5C. 5A is a secondary referral hospital, which can be within the county referral hospital or the regional referral hospital. Then we have the specialized inpatient hospital at 5B. And in this case, it means like they offer inpatient services within a particular discipline. So for example, within obstetrics and gynecology, so they don't offer other services. Then 5C is a subspecialized clinic, which will be run by your medical or dental subspecialists. So at this point, the medical specialists and the medical and dental subspecialists are a mandatory requirement. Level 6 is split also into 2, where we have 6A, which is a general tertiary referral hospital or the national referral hospital, and 6B, which is a subspecialized inpatient hospital. In this case, it's now within a specific discipline and has gone on to offer subspecialist services within that discipline. So for example, our obstetrics and gynecology hospital now offering services, say in oncology or maternal fetal medicine, something like that. So they are at a higher level, but they are concentrating only within one discipline. They will not be offering, say, internal medicine or general surgery or the other services. They will not offer that. At this point, again, similar to the previous classification, it is mandatory to have medical and dental subspecialists. So as I mentioned, the categories are actually contained in the rules, and the rules usually contain a schedule which lists the facility level and a description of what the facility offers, then the services that are offered within that facility, the infrastructure that is required to support those services, and the personnel that will then now offer the services. This is distilled to the inspection checklist, which are most likely what you will see as coming with to the facility. And the checklist generally contains 7 sections. The first one is a facility administrative section information. Then there's a section on mandatory requirements, which are what is required for that level of facility. If those are missing, then it is very difficult for that facility to meet the requirements to be that level. Then there's a section on services offered, another one on infrastructure and equipment, and the personnel. So whereas the rules may say like you need medical officers in this level, the checklist now will be specific. It will say you need 10 medical officers for this level. Then there is documentation, and this will include everything from licenses to personnel files, contracts for outsourced services, SOPs, job aids, and other documentation just to make, to prove that these people are offering services as required. Finally, there's a section on scoring. So for each section, there is a score that is attached to it. And that score is what is used to determine what action will be taken after the inspection. Generally, based on the score that the facility offers, it will fall into one of these 4 categories. So those that score below 40% are considered non-compliant. And for this, the recommended action is either to recommend closure or give 3 months to comply, then reinspect. The next category is 41 to 60%, which are considered minimally compliant. And these ones are usually given 6 months to comply with the requirements and then reinspected. The ones who score between 61 and 80% are considered fairly compliant and are usually given 1 year to comply with the requirements and then reinspected. And those who score above 80% are considered fully compliant and can be placed on a routine inspection schedule, which means they will be reinspected after 2 years. So in conclusion, KMPDC is mandated to regulate the training and practice of medicine and dentistry. And through its functions, KMPDC ascertains that practitioners and health institutions have the capacity to provide quality health care. However, it is important to note that a lot of our functions are concerned more with the structural capacity of to provide quality health care. And in that case, they constitute an indirect measure of quality healthcare. Whereas patient outcomes are actually a direct measure, and some of these can actually be noticed in terms of the complaints that are raised by patients or their relatives against the health facilities and against the medical practitioners who have served them. So we may need to go a step further than just looking at the structural capacity to a point where we are able to ascertain the health facility, the health services are provided and that they meet the expected standards, and to somehow link the complaints lodged against, say, a facility to their accreditation or categorization in the future. So moving forward, KMPDC is committed to enhancing quality healthcare in healthcare delivery through inspections, supportive supervision, and continuous improvement. These are my references, and thank you. I welcome any questions or comments.
Thank you, Dr. Kanja. We really appreciate that presentation. It's quite insightful, and looking and seeing how the council has made sure that it's taken care of the facilities and the practitioners, and to enhance their capability of ensuring that they are providing quality healthcare and also ensuring the safety of the patients. Because sometimes we might be tempted to look at it at only the healthcare workers, looking at the practitioners. Are they up to the task to ensure that the patients receive quality healthcare and also that the patients are safe? So it is very important for us to consider that categorization of the healthcare facilities, so that if I'm in a level 3 and I'm having a patient who is requiring ICU care, and I'm sitting there with the patient, I should know I'm endangering the life of that patient, because according to the category I'm placed in, I should not have such a patient in my facility, because they need critical care for that matter. So thank you so much. Very interesting presentation, looking at how you support the quality of management by measuring the care, by assessing the care, and advocating for improvement of our current standard to continuously improve to support the level of quality and safety of our patients. So I would like to open this session, Q&A session, and to thank our two presenters. They've given us ample time to ask questions. You've utilized this time so effectively, Dr. Kanja and Dr. Talam. So like I had sort of estimated when to expect you to finish, and actually you've been on the dot for my plan, so that we can have the participants ask questions. Thank you so much, and I welcome questions. I have a few that are typed. Maybe I can start with the ones that are already typed here. How do a clinician go about on clinic or hospital facility registration? I don't know how you understand that, Dr. Kanja. Is it somebody asking how somebody would register a clinic or a hospital? I'm not sure about it. Probably you understand it better. Over to you, Dr. Kanja.
I believe it's closely related to the next. There's a question also on the requirements for someone to open a medical clinic. Like I said, these requirements are actually listed on our website. As the law stands, it is illegal to run a health facility without it being registered. However, for the facility to be registered, it requires to be inspected, depending on the level, both by the county health team and the regulatory authority. For each level is different. I just gave a very summarized version of what appears on the schedule. But yes, they would require at least to register the proprietors of that facility. If it's like a private facility, that entity would have to be registered with the register of companies. Then they would require to be inspected, like I said, both by the regulator and in this case, KMPDC and the county health team. There's some documentation that they would be required to present. And let's just say all of this information is available on our website if anyone is interested. And then they can just approach the council and have and be guided on that.
Thank you so much.
I can also see another question on from an anonymous attendee. And the question is, in the spirit of UHC, how does KMPDC ensure comprehensive quality care in terms of practitioner competencies in lower levels where transport for referral to higher facility level is not feasible for various reasons? This is an interesting question because now it goes straight to how is the health services, how the health services being delivered. But like Lois mentioned in her introductory statement, why would someone willingly keep a patient who they are not able to handle? It is understandable that in certain circumstances, it may not be possible to travel to transfer this patient to where they can get the services required. And herein comes the concept of having the facilities, all the facilities linked within a network to a higher level referral facility where they can be able to provide consultations to the person in the lower level so that they're able to at least keep the patient alive and in a better status until it is possible for them to institute the referral. Again, for the practitioner, there are the concept of CPD comes in. CPD is not just about, say, attaining the points at the end of the year so that you're able to get registered, but about honing your own skills so that you're able to offer better services to the community and to keep yourself up to date with the current guidelines on professional practice. Thank you.
Thank you, Dr. Kanja. I would like to read through two questions from our former CEO in Nursing Council, Mrs. Oyuer. The first question, first she comments that that's an excellent presentation And then she asked, the majority of health workers in many facilities in Kenya are the nurses. Don't you think the licensing of health facilities should be a role taken by all professional councils, just as we do joint health inspection, which we started way back with help from IFC? The other question is that she asks, the hospitals have acute shortages of doctors, yet we have many who have qualified and not employed. What is your role, I guess, as a council in making sure that doctors are in the rightful place for patient safety? This seems like the last one, like a similar question Dr. Talam answered about the shortage of nurses. Please take it on.
For the first question, I'd like to say, yes, the joint health inspections still continue. And I may not have had the opportunity to mention that in this presentation, but we as health regulators usually conduct the joint inspections. And even for categorization of health facilities, usually the team will have a representative from KMPDC, from the Clinical Officers Council, from the Nursing Council, from the Medical Laboratory Technologists and Technicians Board, and from the Kenya Nuclear Regulatory Authority, the previously known as the Radiation Protection Board. At the minimum, these ones will have to be there, especially for the higher level facilities. It is true that a lot of the facilities are manned by nurses, and so sometimes the team may not have all these members that I have mentioned, but usually our teams will have at least 2 members from one of the other regulators who will join us for that inspection. In terms of the shortage of doctors, we can enforce and we do enforce the requirement that the facility has to meet the minimum criteria for it to be considered functional, for it to be categorized at a specific level. When I mentioned the section on mandatory requirements, for a service to be considered functional, there has to be at least both the equipment, say, if we say a functional laboratory, we would expect that the lab is there, the equipment are present, the reagents that one would need to run them are present, and the staff who will run this equipment are also present. If it doesn't have any of these components, then that laboratory would not be considered functional. It is the same thing with the health facility. If you're required to have a functional ICU and you do not have the personnel who can provide ICU care, say like a critical care specialist or an anesthesiologist, then you cannot consider that a functional ICU. And for that reason, that facility will not qualify to be classified at that level. I think I will also ask our CEO to comment on that.
Thank you. Dr. Kariuki, please chime in for that question.
Thank you. Which was the question we were dealing with currently, maybe?
Shortage of doctors. The question reads, the hospitals have acute shortage of doctors, yet we have many who have qualified and not employed. What is your role in making sure that doctors are in the rightful place for patient safety?
Well, thank you. As Dr. has just mentioned, one of our key roles is to ensure that there is a pool of qualified practitioners, in this case, medical doctors, dentists, and oral health officers, while other regulators make sure there are enough numbers for the related professionals. So in this particular case, when it comes to doctors, Once we register them, we make sure that they are available for employment. Remember, employment now is a slightly different mandate from the council. But part of our work is to work with the Ministry of Health to come up with the standards on the number of doctors that are expected. Looking at what the WHO has given us as the minimum requirements, and looking at our country and giving, for example, saying that maybe there should be one doctor per every general ward bed, 10 of them, as an example. But this then gets agreed and is put in the health sector documents. For example, the Human Resource for Health strategy or norms and standards, after which then the council can follow up with facilities to make sure that they are keeping as close to those standards as possible. Remember, employment also is based on availability of resources. So it's a matter also of negotiation and agreeing as a country on what the areas that we shall need to enforce to ensure that patients receive quality care. So not a question that may have a real direct answer from KMPDC, because it requires a range of stakeholders to be able to achieve. That would be national and county governments, the treasury, the private sector, who are also major employers, to be able to come to an agreed position on how we can have as many of the doctors that are qualifying being absorbed in the country. Remember, we also do not deny those who may want to work outside of our borders. We do issue them with the certificates to confirm that they are trained and are recognized in our country. Thank you. I hope that helps.
Yes, Dr. We thank you for that very clear explanation and the answer to the question. And I because I have the mic and I'm the moderator today, I would like to ask you a question in relation to the community health practitioners. We have, this is where we are shifting to, and as far as the community level healthcare is concerned, what is the medical council doing to regulate and to ensure that there is quality, particularly at level 1s and level 2s?
Well, thank you. I think maybe I start by saying that our understanding is that community health promoters are community-owned resource persons, not necessarily technical health workers. And so the issue of their regulation may not arise because they are not a recognized cadre as for regulation. We can only discuss about their supervision and guidance in the work that they do. And therefore, we do expect that if they are going to be linked to a health facility, because that's our expectation that every promoter is linked to a certain health facility, then that health facility will be in charge of ensuring that the community promoters are performing to their expectations, which are largely health promotion and prevention, not curative and not necessarily curative services. So the services that would normally be offered, maybe even over the counter at a chemist, for example, if allowed to issue a mild painkiller as an example, that maybe is the scope. And I believe that the Ministry of Health, through the Community Health Unit, should be able now to provide the detailed information about what we expect of services at the community level. If the council is given an opportunity to regulate community level services and issue maybe licenses for purposes of quality, then would be happy to take it up. But for now, we believe that the community health promoters are linked to a supervisor who is maybe based at the nearest facility or appointed by the county or through the primary care networks that we know are being formed for purposes of a referral, a referral system for services, that the supervisor will be a qualified health professional who can be able to be answerable for any, let's say, acts of omission that may be done by the community promoter. I don't know whether I've gone to the right, I've answered you, or I need maybe to clarify. Thank you.
Thank you, Dr. Kariuki. I am happy with the answer. And my concern is mainly because of the kit, the promoters. I know earlier I had said practitioners, they are promoters, community health promoters. They were given a kit, which I understand it has some antibiotics like amoxicillin. So I wasn't sure of, and I know many of us are not sure how they are going to use that kitty, especially in the current era of fighting antimicrobial resistance. So if, as you have said, they have a supervisor, probably they will be using the medication in conjunction with their supervisor. Because having an amoxicillin there it's a scary thing for some of us who deal with infection prevention and control, and more so on the area of antimicrobial resistance. Thank you so much.
Yes, and it's true, and that's why I'm saying that maybe there are some parts of details of exactly what their full scope is still not clear to all of us, so that we can be able to advise on how we can regulate. Because if they are going to use antibiotics, we would want to know, under whose supervision that will be done, and in what situations, and such things. But I'm not maybe the only. I would also want to hear maybe Dr. Lydia's opinion on this, because this is not necessarily a KMPDC position. I've just given it as a health professional largely, and with my knowledge on regulation. Thank you.
Thank you, Dr. Kariuki. I welcome Dr. Lydia Okutoi, the SQH-K president. Dr. Okutoi, as you answer that question, kindly also answer this as our last question. Lillian is asking, at county level, can we be able to have SQH-K? So as you answer the question on community health promoters, please answer that one and close for us the session. Thank you.
Very much, Dr. Stella and Dr. Kariuki. We are truly grateful for the Kenya Medical and Dental Practitioners Council taking time to come and highlight the role they play. As much as we are at times afraid of the person who comes with a stick, but for the common good, you do a very important role to protect the public. And so we thank you for the slides and information shared. So with regards to the community health promoters, I'm just smiling when the question was coming, because I think I may not be the best person to answer, but we have a lot of interest in how this unfolds. And so our assumption is that we have looked at the possible risks with it, and that as a country we have put safety nets or opportunities to prevent that harm going to the patient. However, task shifting has been used in many other circumstances, but for this part, I think we are still waiting for to see how it unfolds. But we are of the opinion that the having antibiotics and having some level of judgment to make a decision on how and when to ask the patient to walk to the hospital or call the ambulance or to just assess an emergency is something that we will maybe need a learning curve around with these community health promoters. And so since there is a specific department that is supporting this, and then also there are, I think, some webinars on health financing at 7, is it on Tuesdays or Wednesdays? There was one last week, and so I think there will be a series on health financing and the mechanisms that the government is using to just increase access. Yeah, so as we increase access, we look at quality and we look at what are the benefits. And so I think we as stakeholders, the healthcare workers and Wanjiku, we have a role to give a voice and to see whether this works. So the intention is good, is to increase access, but now the risk associated with it, I think we will be able to see how that unfolds. But from the conversations that have happened, we've attended several sessions and meetings. We are told that they are not working in a vacuum. They are public health officers, and then they are their supervisors, and some are nurses, some are doctors. And so how we do that community unit, what we call the level 1, the level 1 part of care will be a showcase of how this can work in a region like ours. So we remain open and hopeful. Yeah, about Society for Quality Healthcare, we are a multi-professional society, so it means that Dr. Kariuki is part of our regulators, Dr. Talam, the clinical officers council, and all those. So in fact, for us to be registered in 2020, we had to have a letter of support from the board, because they know that our role is very much related to all the cadres, including the ones that they regulate. And so we are a professional association. And so as an association, it means this is membership driven, and such encourages self-regulation in terms of autonomy. It helps us lift the standard of care for the patients wherever we work. So the members are coming from all the professions, and we are open for membership. And there is a mechanism. You can find us on LinkedIn. Then also we have a group for which we would be having an open day at some point next year, so that people can now register as members. And so societies are grown by the members. And so regardless of county or cadre, any healthcare profession, or teams that relate to patient advocacy, like those that are for sickle cell, for leukemia, the patient advocacy groups, the ones that try to ask for improvement of care for a specific theme, plus there are groups that look at patients' voices just to make sure that they are heard. We had the board, the medical council tell us of the Patients' Rights Charter. So all those, that was brought by a patient. So it means patients by themselves have a voice in ensuring that there is quality of care. They are important stakeholders. And so society is welcome to any such voices to be members, and together to be part of what drives the quality and safety of care in the country. And so we'll have, for example, now I'm in KNH, there are people who are coming from private sector, they are from teaching institutions, there are others from patient groups, there are radiologists, pharmacists who are parts of the Society for Quality Healthcare. And so I think you are welcome to participate in the society. If you follow us on LinkedIn, you can be able to type your email or contacts there, and we will get in touch. Or in case, Lois, you can put in the chat, I can put the WhatsApp link in case someone is interested. I'll put it in the chat. Those interested can get information there, and the process of membership can be explained on how that happened. So allow me to just appreciate our excellent speakers, excellent by virtue of the knowledge and information they have, but then also the role they play, being our regulators, ensuring that indeed there is oversight, that the care that we give will not cause harm, and that also we as practitioners, we are competent and we are ethical. So you play a big role. And so we appreciate Dr. Edna Talam and Dr. Stella Kanjan, and also truly glad that Dr. David Kariuki was able to join. And thank you so much, Lois Kihungi, for moderating. Lois is a member of the Society for Quality Healthcare. So we truly appreciate. So on behalf of the KNH management, who are our hosts at the University of Nairobi, asanteni sana. Thank you.
Thank you very much. I think that marks the end of today's presentation, today's conversation. Please have a great afternoon and the rest of the day. Thank you very much.